All right, so I'm here at the Royal Canadian Military Institute in downtown Toronto with Dr. Brian Goldman, who, amongst other things, is a radio talk show host of CBC's White Coat, Black Hat, prominent author of at least 4 books, if I'm correct?
4 books.
4 books, including one that we're going to talk about today, The Power of Teamwork, and also The Night Shift, which I don't have with me, but which we will talk about. And on top of that, if it wasn't enough, you are also a practicing medical doctor.
Emergency physician.
Emergency physician.
Right up the street at Sinai Health System.
Right on. So I've got you here today. There's some really interesting perspectives on the power of teamwork that have an aviation nexus, which is my background. So that's part of the reason why I reached out and hoped that we could have a discussion on looking at what we can do in healthcare to implement some of the valuable lessons learned that we've had and the developments with threat area management, crew resource management, safety reporting, and so on. That
paid for, as Sully Sullenberger once told me, in blood. Those lessons
That's right. They're
paid for in blood.
They're paid for in blood, exactly.
Yeah.
And we ignore them at our peril.
Yeah.
You obviously are no stranger to these facts, and you've mentioned them at length in both books. I've only read 2 of the 4 books. What are your other 2 titles?
So the other 2 books are The Power of Kindness, Why Empathy is Important in Everyday Life. And it's basically, it was my quest to meet the kindest people on the planet, learn their stories, and find out, learn about their acts of kindness, but then ask questions like, were you always that way? Were you born that way? And some people are hardwired to be super empathizers. But I think the majority of people develop deep empathy by suffering. They've suffered a loss in childhood, a divorce of their parents when they were small kids. Maybe they lost a parent, or they suffered, terrible dislocations from immigration, moving to another country, having to start over, whatever it is. And they became kind, and they developed kind of an empathy for other people in similar circumstances. And then the other book that I wrote, which is kind of if the power of kindness is the yang, the yin was the secret language of doctors, which is basically a look at the culture of modern medicine, warts and all, as evidenced by the slang that we use to describe unpleasant situations in patients and family members as well. And I got a lot of criticism for that book, and to cleanse my palate, to get out of to overcome that, I wrote The Power of Kindness.
Right on. Who were among the most kind people that you met while you were on that journey of writing that book?
I met Dylan Glass, who is a computer programmer who was developing Erica, which is an android. Call her a kind or empathetic android. Okay. So he was all about creating simulated empathy. And one of the things I met Dylan in Japan, his kindness, I think, came from isolation, a sense that he was different from other people, okay. And but he had one redeeming close relationship with his dad, and the 2 of them used to go to the local junkyard and fish out old batteries and old parts and make beautiful things like. Now this is your thing. Is it a trebuchet?
Yes. Yeah. Okay.
Yeah. So they would build catapults.
Nice.
That's
a very military thing to do.
A very military thing to do. But he went to Japan to teach English, and then he was already a computer programmer, and he was interested in robotics, and he met up with a man named Hirogoshi who told him that he could get paid for doing what he loved to do, which is to create Erica. Erica is an empathic robot. So that was one of the kindest people that I met. And then another woman, Shala Montero, who lives in Sao Paulo, befriended a homeless man, a man who had been homeless on the streets of Sao Paulo for over 40 years, 19 years in one patch of like an island between 2 large boulevards in the middle, right near the University of Sao Paulo. And where did her kindness come? So she befriended him. She built a Facebook page featuring this guy who everybody had stepped over, and suddenly he became a celebrity. And then suddenly his brother said, "I know this guy," and so she reunited him with his family of origin.
A beautiful act. So expanding on empathy maybe in healthcare. I was going to leave this to later in the conversation, but it seems like certainly frontline first responders and ER doctors have no shortage of trauma that you're witness to, and not only from the patients but also the patients' families. Dealing with death, not an easy thing to do.
Nope.
There's obviously overlap there, perhaps with other first responders, law enforcement, and with the military as well, but in a different way.
I've interviewed paramedics who have very severe post-traumatic stress disorder. So there's a strong kinship between paramedics and other first responders, law enforcement officers, and the military and firefighters who witness trauma firsthand and are often so overcome by it that they become so impaired that they're unable to work.
You're seeing it day in, day out over the course of potentially decades of a lifelong career. Yeah. I wonder. Obviously, it's important to retain a sense of empathy, especially for your patients. But there must be a certain stealing over of your nerves or a dark humor that manifests itself amongst both physicians and nurses who have to deal with that in order to be able to go on doing the job that you're doing.
So that's true. Dark humor is important, and one of the reasons why I was interested in the secret language of doctors is that there's a lot of dark humor in the terms that are used, for instance, to describe death. Right. A patient who is waiting in the ICU to die. Sometimes the expression we use is actively dying. And care has been withdrawn. They're receiving comfort measures only, and the family is coming to grips with. They're gathering. They're coming to grips with the fact that their loved one is dying. And meanwhile, outside the ICU room, in the room where they have rounds, or just outside the hall, they might be saying something like, Mr. Jones is waiting for a pathology consult. Pathology meaning death, autopsy, okay. And or is about to be admitted to the 19th floor of an 18th floor hospital, okay. Discharged to heaven. Those are, and that's one of the ways that we cope. But I think in many respects we don't cope, and that's humor is a device, but we find it very difficult to empathize because the feelings are overwhelming.
I mean, for most of us, death it's a rare and unpleasant thing that punctuates certain periods in our lives, usually with loved ones or friends, and it's not our profession to deal with it.
No.
It's the most unpleasant of days, and then we struggle to move on for the rest of our lives.
I'm grieving the death of my sister right now. She passed away just almost 4 months ago, and I was her caregiver. I was her essential family caregiver. And she lived in long-term care for the last 7 months of her life, and I can tell you that I'm grieving. I'm still grieving. Partly because I'm the last surviving member of my family of origin. And I didn't think that was going to happen. I would have thought, 10 years ago, when my sister and I were taking care of our parents, that we would have a good 10 or 15 or 20 years to reminisce and to grow old together, and that didn't happen. She had young onset dementia. So you're absolutely right. So I now have empathy for a lot of my patients who are grieving, because I've been there. So if we haven't experienced death ourselves, we find it hard to empathize with our patients. And that's why younger physicians, nurses, respiratory therapists, they have to live a little. They have to grow into their adulthood, begin to lose their parents, right, to begin to have an appreciation of what it's like to be our patients. Very hard to empathize with the situation that for which you have no kind of frame of reference. So that's one thing. The second thing is, for people, and I'm an emergency physician, and when death happens suddenly, unexpectedly in the emergency department, the reaction of family members is understandably very strong. So,
in terms of laying blame or
just being grief-stricken, shocked, and the first time I have that conversation, first of all, if I'm afraid that I'm about to be blamed, that's a terrible attitude to bring into a room where you're telling somebody that their loved one has died. And I've had to learn how to put that aside and be there for the patient. And it's not just a method. There are ways of approaching somebody, breaking bad news to them, but you also have to be able to park any feelings of internal distress that you have, and we're often not good at that.
No, it's a tremendously difficult thing to do, and it's a non-medical aspect of your profession that you have to debrief a close family member in that way, often when emotions are highest.
Yeah. And there are triggers. They might say, what happened? What happened? What happened? And you can feel the tension in the back of your neck. They want to know where I've screwed up, or, was there a moment when things could have gone differently? And, and I can't lay it on too thick and say that we say that we did the best we could. Sometimes it's obvious, often it's obvious, but sometimes there's some uncertainty and doubt. And there are some families that will magnify that uncertainty and turn it into a quest for justice.
Which in turn makes it very difficult to create the kind of safety environment you talk about, not only in your books, but in your TED Talk from many years ago, late 90s?
It's about 11 or 12 years ago. Yeah, doctors make mistakes. Can we talk about that? I did it just off the street on Bloor Street at the Royal Conservatory.
And in it, you mentioned it is, and you really have to underscore the fact, sad that we do, because it should be obvious to anybody that it's not just incompetent doctors that make mistakes. Everybody makes mistakes. It's a time-compressed environment, complex adaptive environment, and in some cases, symptoms are misrepresented, or fatigue creeps in, or one of any number of factors creates an adverse incident.
It's so easy for you to say that. In medicine, we don't say that at all. I mean, we're beginning to talk like that. We're beginning to adopt some of the patois that you've just described. But in our culture, it's I alone. I alone. Stride into the resuscitation room, bark orders, and know exactly, I figure out what's wrong in 10 seconds, and I bark orders, and the patient lives, and if they don't live, then I must have screwed up. And that's we say things like, if I need a floor cleaner, a service assistant to point out that the oxygen is no longer attached to the oxygen delivery device in the in the wall in the resuscitation room, and that's why the oxygen saturation is going down in the patient, then I don't deserve to practice medicine. If I can't read this EKG, for instance, we have a procedure in the emergency department where time is heart muscle. You don't want to miss a heart attack. Seconds count, minutes count, seconds count. You want to get the patient to unblock their coronary artery as soon as possible. And I have had instances in which people have shoved an EKG. What the nurses do, according to the procedure, is whatever you're doing, they shove an EKG in front of your face and say, "Here, read this now." And
regardless of what you're doing at the time.
Regardless of what you're doing, you might have a septic patient here and a code stroke patient here, where you're waiting to get a call back to transfer them to a facility where they can unblock one of their carotid or their cerebral arteries. And then in the middle of or you might have just dealt with a patient and their family who are yelling and screaming about the fact that they've been waiting 2 hours to be seen, or waiting for a surgical consult, or waiting for a CT, or waiting for a report of a CT scan. And there's a lot of tension. There might be microaggressions going on, tension between different professionals. And in the middle of all this, a nurse shoves an EKG in front of your face and says, "Here, read this." And I've had colleagues who have said to me, "You should have dropped everything and dealt with that first." It's hard to make those judgments.
You must be familiar with the term sterile cockpit, and how it on the flight deck.
No, but
during
tell me what it means.
critical periods in the flight. No interruptions are permitted. So we call it a sterile cockpit. If you're running through a specific checklist, if you're in a certain phase of flight that's considered critical, the task at hand must be completed before anybody introduces a new irrelevant piece of information.
They tried in healthcare. There are nurses, like chemo nurses, who would make grievous mistakes in dosage errors, and patients would die. Wrong delivery system, wrong dose. And they put literally a cone of silence over their head. Try not to laugh too much. I mean, the whole idea is to remove distractions. In medicine, we believe that a competent physician can multitask, can listen to a million distractions going on all around us. We have in our emergency department an intercom system that begins with a beep that, I guess the first time I heard it sounded okay, but it has become progressively more and more irritating, and it breaks my train of thought every time I hear it. It's kind of it's like a whistly tone, like bump. And it's annoying, and then by protocol, the person makes their announcement, and then does it a second time. And whatever I'm doing at that moment, I stop and pay attention to that as if it's the most important thing. There's no curator. There's no concierge who is saying, Brian, you need to do this first, then this, then that, then that. So I love the idea of a sterile cockpit. I'd love to have a sterile resuscitation room.
Have you ever heard of anything like it being trialed, aside from the cone of silence that you mentioned? Is this a subject that's been pursued anywhere in healthcare that you know of?
There are a million pilot projects, but one of the limitations when it comes to healthcare is the medical mind that says that until you prove it to me, I don't need to pay any attention to this. Right. So it would be unusual to have a single initiative that is piloted and found to be so successful that everybody adopts it all at once. Now, there were in medical history, for instance, the idea of counting instruments in the operating room so that you don't leave any inside the belly. Yeah, there were cases. Case law came up maybe 100 years ago where, you can't just say, shit happens. We left a scalpel, or we left forceps in the abdomen, and so that changed overnight. Okay. But a lot of these initiatives that you're talking about, I'm sure they've happened. Oh, sure, we know distractions are important. Yeah. Are you aware of the OR black box?
So I read it only through the book, The Power of Teamwork. Okay. You mentioned it in one of the chapters, so that's the extent of my understanding.
So the OR black box is a perfect example of a technology that should be adopted everywhere, but it's a hard sell. And so just to explain it, it's patterned after the flight data recorder and the cockpit voice recorder. It's supposed to capture visuals, audio, and data during the entire operation, and it also captures the environment, whatever was going on at the time. So if there were distractions going on, for example, people going in and out of the operating room is a distraction. It not only introduces the risk of infection, but it's also distracting. And there are, the surgeon, Dr. Theodor Grantcharov, who was the genius behind it. He's the team leader. He hasn't invented it, but he shepherded all the parts to go into the development of the OR black box. He says that there are surgeons who cannot continue operating until they know what the distraction is about, why that person's gone into the operating room. So yeah.
There have been crashes, actually, from similar incidents on the flight deck of aircraft.
Yeah.
Pilots becoming consumed with random stimulus that is not actually relevant at the time, and subsequently either losing situational awareness on their fuel and crashing, or crashing for other reasons.
So I talked about the OR black box because I think it's a promising initiative, but Theodor Grantcharov has had to be very careful in how he introduces it to institutions like Vanderbilt and MD Anderson Cancer Center and Duke University. He introduces it, first of all, by pixelating the video and by disguising the audio so that there's no name, no shame, no blame.
Okay.
Because we're very good at that in healthcare. We don't like uncertainty. And there's a lot of uncertainty surrounding mistakes. There's surrounding bad outcomes. I said mistakes because they're not always mistakes. Right. They might be, multi-layered, complex. Yeah. But one way of ending the uncertainty quickly is to find somebody to blame. And unfortunately, we do that all too often in healthcare. And I can tell you something. In our medical culture right now, when we want to get rid of somebody, we just don't like who they are. Maybe they're getting a little old. Maybe they're getting a little set in their ways. They've got a little too much attitude. An easy way to get rid of them is to pounce on the first mistake that you've detected that they've made.
Not indicative of a healthy reporting environment.
No, it's not.
But it wasn't always the way it is now in aviation. in the 50s and 60s, I think it was probably fairly similar to what it is in healthcare right now.
Right.
And there was certainly a power gradient where the captain on the flight deck was always right. The loss rate of aircraft was quite high, and it was just assumed it was the cost of doing business. It's a dangerous environment, and we train like we fight, and so on.
And they would have been, forgiven for believing it was because of the complexity of technology.
Exactly.
And in part it was. But most of the mistakes, turns out, according to that famous NASA report, were due to human factors. Bad communication.
Yeah, and even now, I mean, technology has improved considerably.
Yeah.
Our safety with the human factors in aviation systems side of things, and the way we treat teamwork on the flight deck and crew resource management has improved considerably, but it's improved at a slower rate than the technology that we've adopted. So consequently, in the late 2000s, the error rate, the primary cause of 80% of general aviation accidents in the US was human factors, pilot error. Even though it's a pretty healthy model for how to share things, not only that went poorly, but that went very well, so that everybody can learn from one another's mistakes.
And you're light years ahead of healthcare.
So I know in aviation we had the benefit of centralized governing bodies like the FAA, the NTSB, Transport Canada in Canada, CAA in New Zealand, and they were able to mandate that certain carriers, Part 121 carriers, or the Air Force adopted specific crew resource management, human performance in military aviation, flight safety models that became self-regulatory in a sense, who were charged with the responsibility of increasing aviation safety. So they were able to do that kind of from the top down, whether people liked it or not. It was mandated, you shall take this training once a year. And over time, people became more and more not only aware of the training and the intent behind the training, but encultured, I suppose.
But you've also, and don't sell it short, because you've become successful. You have outcomes. It is vanishingly rare for a passenger plane to go down. I mean, it happens, but not at the rate it happened 40 or 50 years ago. And I haven't seen any equivalent in healthcare. Now, part of the reason, we're also, like aviation, healthcare is becoming a lot more complex. We're dealing with patients who are older and have 10 diagnoses. We're able to find more, discover more, treat more. The treatments themselves are more complex. There's a greater risk of drug interactions. There's interactions between technology and the human and the human patient, and instead, like, I think at some point the analogy between patient and aircraft breaks down. I think human beings are a lot more complex. And I think you're dealing with thousands of diagnoses. You're dealing with one plane and the avionics, and the general principles are the same. And
I would agree. Healthcare is far more of a complex adaptive system, and aviation, while a complex system, can be maybe relegated to a complicated system at times rather than a complex.
Yeah.
And
and I say
it's not as litigious either.
No, it isn't. But I think it's harder to do the studies that can demonstrate conclusively that we can zero the error rate, or we can improve outcomes by zeroing or substantially reducing the error rate. Now, there are very specific successes. One of them is heart treatment. Developing a time is muscle approach. So that what you want to be able to do is arrange the system so that you're diagnosing the heart attack as quickly as possible, so you can get the patient either blood thinners, clot-busting drugs, or get them to a catheter suite where you can do an angioplasty and unblock that blocked coronary artery. There have been great successes there. A little less success on stroke management, but also successful. So there are very specific examples, but those are 3 or 4 out of thousands of diagnoses. And and there are we can do across the board initiatives like reducing catheter infections in elderly patients by by taking out the catheter as soon as possible instead of using it as a tool for patient management. Use it to get a urine sample if you need it and remove it as quickly as possible so that the patient doesn't get infections. But that's creating rules that improve safety and better patient outcomes.
Would it be fair to say it might be easier to advance safety in healthcare from a medical device standpoint rather than a culture standpoint, in that you can bring a medical device through a series of trials, you can demonstrate in the trials that it has fewer adverse outcomes than a competing brand or a competing medical device, and that it's a technical solution that's more easily adopted, whereas trying to drive home that the culture towards how we perceive risk or how we perceive error needs to be changed over a multi-year, perhaps multi-decade long approach before you're going to see the decrease in incidence.
Yes, I think in theory the answer is yes. The problem, and there are a number of problems, unlike avionics, unlike communication devices, radar devices, proximity detectors, whatever kinds of devices you have on aircraft, you have systems that are designed to talk to each other. What if I told you that in healthcare, in the intensive care unit, that the cardiac monitor doesn't talk to the blood pressure monitor, doesn't talk to the temperature monitor, and that different device manufacturers have a source code that they could share with one another, but don't share it with one another because it's proprietary. Like, we're shooting ourselves in the foot, and patients are suffering at the same time.
And that places an additional burden on the healthcare professional to be the intermediary between all of these systems that don't talk with one another.
Yeah, and bear the consequences because it's got to be somebody's fault. Right. And I know I'm sounding like a cynic when I say that, but I think the difference between Sully Sullenberger, who I had the pleasure of interviewing on White Coat Black Art, one of my idols. Anthony Fauci was another one, and I've gotten to speak to some great luminaries. But Sullenberger talked at length. He's now become, now that he's retired, he's become a consultant and is trying to teach the lessons of aviation safety to healthcare.
Really? Okay.
Yeah, he is. So he told me, what are some of the differences between dealing with the consequences of aviation mishaps and dealing with medical malpractice? First of all, a shared sense of destiny. That if the plane goes down, it's not just going to kill the passengers; it's going to kill the cockpit crew and the cabin crew, and I can tell you that until COVID, we tended to have this dichotomy where, the patient, the surgeon's going to feel very bad, the anesthetist is going to feel very bad, the internist, the emergency physician, the nurses, but they're not going to die. They're not going to suffer the consequences. That's not exactly true. I don't know a physician or a surgeon or a nurse, respiratory therapist who wants to be party to a negligence lawsuit, to have to relive those moments again and again and again where everybody knows what you did in retrospect. Dealing with college, complaints to the College of Physicians and Surgeons, the College of Nurses. I don't think anybody wants to. In fact, I've met plenty of healthcare professionals who would take 10 years off their life to undo a mistake, if it's grievous enough. Until COVID, there was no sense of shared destiny. With COVID, that was the first time in my lifetime, in my professional life, that I saw a shared destiny. That suddenly the same disease that could kill patients could kill healthcare professionals too. And boy, did we suddenly galvanize together. You had these protected code blues where once it was called in the hospital, people would rush from different parts of the hospital and they would all be there. How can I help? How can I help you? Which we often don't have in healthcare. It's kind of like, it's your problem, you deal with it.
That brings up an interesting point, because we talk a lot about sharing the mistakes that happen, and that obviously is actually a healthy way of viewing things if we're ever to learn from any of them. But we also ought to share the things that go well. And with the code example, I've got an observation here from one of your books about a a code orange from a mass casualty event, and I'm trying to find
in
it
Ottawa.
here. In Ottawa, and how it galvanized an entire team together. And I just wonder if examples like that are well shared, so that other people who perhaps will never experience, or maybe only have a mass casualty event once every 10 years, they can learn from everything that went well and then try and replicate it. In the same way, Sully's incredible landing on the Hudson is a perfect example of something that's been well shared because it went so well. So probably pilots everywhere have watched it, read the book, thought about it to themselves. Now, what would I have done? What could I do if I'm in a similar circumstance? So, was that well shared? Are there some things that happened during COVID that galvanized teams together that people ought to know about but don't?
Oh yeah, I think so. And I think the example, the Code Orange that I wrote about, that was involving OC Transpo, and it was a bus that crashed into a station, and the top was sheared off, and it was a mass casualty event. And the interesting thing about it is that it followed another Code Orange in which the Ottawa hospital prepared to receive mass casualties and received no one, and they wondered how that happened. How could that have happened? And they did a root causes analysis and did a simulation. And funny thing, that simulation that they did, which they completed days before the actual incident, resulted in a textbook operation. Okay. It was well done, and it was well disseminated within the Ottawa healthcare community, within the Ottawa hospital and the Ottawa and the allied services, first responders. And so they learned some lessons. One of the lessons they learned was two-way communication. So you have the paramedics in the field communicating with the dispatchers and giving them a perfect sense of, or at least an optimal sense of, how many casualties there are going to be and who's going to go where and how many minutes until they arrived, and oh, by the way, it's in the middle of the winter, there's hypothermia going on, are we going to be treating that as well? Yes, we need to treat that as well. So all of that came from dealing with a bad situation, and it is so important to talk about mistakes. Because that's the royal road to improvement. Yeah. And that's the hang-up that we often have in healthcare, that we don't like talking about mistakes, except in a way that's medical legally kind of sanitized, so that there's no chance that a lawyer is going to, or lawyers are going to kind of research this topic and find pleas of guilty, people admitting guilt, and so that they can just cut straight to the settlement.
So on that topic, just a couple of quotes that I noted from your book, The Night Shift. You mentioned, I believe one of our responsibilities is to create a culture of safety in hospitals and doctors' offices. Doctors must feel as though they can admit they have erred. And then you gave an example of discussing your own, an error that had occurred in the company of other physicians, and how you got the impression that it was making them feel awkward. Yeah. So how do we move beyond that culture? And you gave some comparisons with we talked about it already, the death rates in aviation, on the order of 50 to 60 per year, as compared with the same order of magnitude per day due to adverse incidents in medicine. You mentioned a case reported by Dr. Landrum about a nurse requesting he replace the attending ER physician who was treating a motorcycle crash victim. It was on White Coat Black Art. And the attending physician was doing a poor job of dealing with the patient. Dr. Landrum, who was asked to basically intervene, commented, it wasn't a medicine issue at all. The medicine isn't the challenging part. It's all these administrative and personal issues that come up. Kind of speaking to the culture of how do I manage this situation? It's going poorly, but I don't want to necessarily tread on toes. And how do I deal with?
Well, there's an art to that. There's an art to that,
right.
And it shouldn't be necessary to shame the person into backing down. You should be able to have a quiet conversation, and one of the ways to do that. Well, if I were running the system, I would have simulations in which I designed them so that every bad thing that could possibly happen would happen all the time. I would want people to feel comfortable if the aim was to say, that like, would you like me to take over? There's a way to do it. And I'm less tired than you are. I've just arrived here half an hour ago. You've been here for 8 hours. I know it's your patient. Would you like me to take over? Sure. But we deal with the consequences, or we live in fear of the consequences. And there's this, one of the things, we started this conversation by asking a question. You asked me about empathy, lack of empathy in healthcare, and I haven't told you the major reason why we don't have empathy in healthcare. I believe it's shame over making mistakes, shame, or anticipatory shame, the kind of toxic shame that we tend to feel when we make mistakes. And I'm not talking about the healthy kind of shame, which is more like guilt, the idea that you slipped up a bit, but you'll do better next time. It's reparative. You want to find out what you did wrong so you can fix it. Toxic shame is living in this almost morbid dread that with your next mistake, if people found out how flawed you were, they would immediately fire you and they would excommunicate you and tell you to leave the group, which is your fear that you're not worthy, that you don't belong in the group. And I think a lot of us in healthcare, I can't prove it. I think a lot of it. I think shame is more pervasive than we let on. If you looked at the literature, like the psychology of physicians and other healthcare providers, going back maybe 15 or 20 years, you'd find that the word shame was not mentioned even once. Now we're starting to see a respectable literature developed. Yeah. And I'm mentioning this because when you're in the throes of shame, you can't empathize with other people because you are so terrified that other people are going to discover your mistakes that you block communication. You don't want people to know how you're feeling. You don't want people to know what you're thinking. You certainly don't want people to have an open kind of a sense that they can read your mind. And you tend to be hostile with patients, curt, hostile, particularly if you've made a mistake recently and you're terrified of being discovered. Just think about how bad, how unproductive that is to developing a culture of safety.
A high consequence environment, it leans toward thinking about yourself, having to put yourself first if the consequences are severe. There's an example from the night shift. You mentioned with respect to fatigue, if you make a mistake, don't ever admit that sleep deprivation played a role.
Right.
Yet the shifts it's well known, the shifts are extremely long, especially for resident physicians, 24 to 36 hours. And of course, we all understand the medical literature on what it means to be fatigued. And
it's equivalent to alcohol intoxication. And I can tell you that I know surgeons and other healthcare providers who've done studies to try to show that that's not the case. We're very good at debunking literature, even when it's pretty obvious that sleep deprivation, that it's not healthy to be up all night, that your ability to perceive. It's not the big stuff. Often we're very good at the big stuff. We can kind of get activated to respond to a resuscitation. But noticing that a potassium is higher than it should be, and that if we did notice it, we would take measures to reverse that. And if we don't, the patient's heart might stop. That's the kind of stuff it's the boring stuff that you don't notice, and it's the boring stuff that can kill patients.
Is there any success stories moving towards a less punishing rite of passage for physicians than having to go through these extremely long shifts where your likelihood of making a mistake or at least encountering an adverse incident, perhaps it's not a mistake, perhaps you just were too tired to notice something very abnormal?
So the answer is yes and no. There has been a tremendous effort. It started with a case of a young adult named Libby Zion. Libby Zion was a young woman in New York City who died of a toxic medication drug interaction. So she was given Demerol, she was on antidepressants, and the two of them conspired to raise her level of serotonin. So she developed hyperthermia and developed seizures as a direct result of that. Her father happened to be a New York Times reporter, and he mounted a campaign. And this campaign resulted in something called duty hours. And so the issue was that the I talked about it in the night shift. So the issue that was raised was that she was looked after by residents, and the residents were up all night and were too sleep deprived to function properly. So this started a process that continues to this day to restrict the number of hours that residents are supposed to work. They're supposed to be able to go home the next day. It's complicated because when a resident goes home the next day, they must hand over to a physician who is a resident who's now presumably well rested, although nobody monitors you to see how well rested you are. I mean, you could have been up all night partying, but you weren't on duty. And so there's literature evidence to show that it may be a trade-off. You may be getting a less sleep-deprived resident, but you're getting more handoffs, and with each handoff, they have to hand over information about the patient, and that in and of itself is fraught with, increases the risk of mistakes because you may forget to tell somebody something really important about the patient. I can tell you that in the culture of surgery, that surgeons have spent a lot of time trying to debunk the value of duty hours. It should be intuitively obvious, but they've spent a lot of time trying to debunk the value of restricting hours. What's the argument?
Why?
The argument is, they're finding, they say, that young surgeons don't have the clinical case experience that they had when they finished their residency, which means they haven't done as many appendectomies, they haven't done as many gallbladder operations or, thoracotomies, chest operations, and there is some sense to that. But the other thing that I want to point out here is there is a strong culture. It's almost like an immune system. It's like the newfangled idea comes outside of medicine, comes from aviation.
Okay.
Restrict duty hours so that you have less tired people. It makes a lot of sense. And so that's the invading idea, and the antibody response from medical culture comes to beat it down with antibodies and just say, get rid of it. And you actually there was a surgeon in the city of Toronto who said, we are not airline pilots, she said. We are fighter pilots. And
I hope she realizes fighter pilots have duty days as well.
I don't know. Maybe they get doped up on modafinil and Adderall, and so that's how they're able to function. I don't know, but I mean, we carry that to ridiculous extremes. But the point I'm trying to make is that, and this comes up again and again and again, that there are lessons from that aviation can pass over to anesthesiology, to surgical culture, but that we are resistant. We're often resistant to those ideas in part because of the shame that I've talked about. Right. That's a shame response when I say if I need a pilot, if I need Sully Sullenberger to tell me how to practice surgery, I shouldn't be a surgeon. Hard to argue with that, except it may not be true.
And it's not even a question of advice on the practice of surgery or advice on the specifics of your particular specialty. It's advice on best practice in terms of how you can function most optimally, which, of course, everybody should pay attention to, which is why pro athletes on occasion look toward the military and vice versa. Special Operations Forces Command will look towards pro athlete from a cognitive psychology standpoint to absolutely get the best possible out of their people. So, I can understand where somebody might be coming from, that these ideas are outsiders' ideas and they may not apply. But, for somebody who's interested in and passionate about human performance, if we want to operate at the best that we're capable of doing in whatever specialty or whatever field that we're in, we probably ought to look at what we can learn from people who are also operating at their best in other domains.
You don't have to convince me. I agree with you. I agree with you completely. And it's one of the reasons why I did my TED Talk. Doctors make mistakes. Can we talk about that? Because I wanted to break through the shame and one way to break through the shame is to simply name the things that you're ashamed of. And every once in a while, you get a physician or a surgeon who has a history of substance use, and they talk about it because that's part of their recovery. And when they do, they're depriving the secrecy. They're depriving that information of its ability to enslave you by keeping it secret. There is an expression that a colleague who had substance use issues, had alcohol use disorder, he said to me, it's in the secrets that lies the sickness. And if the way to deprive those shameful secrets, including medical mistakes, of their power to kind of keep you quiet, keep you terrified of being discovered, is to out yourself. And that was what I was trying to do with my TED Talk. Along the way, I discovered a whole bunch of people who wrote to me who said things like, well, I'm so glad you talked about your mistake because this is what happened to me. And including some people, and one person, this is a story that I held the dearest, somebody who said they were in a hotel room and they wanted to end their life because they'd made a medical mistake. And they watched my TED Talk and they changed their mind.
I wonder how many other people out there were in a similar situation who weren't fortunate enough to watch your TED Talk.
I don't know. I do know that right now among students, medical students and residents, the rate of suicide, suicidal ideation, suicide attempts, completed suicides, much higher than the general population. And I don't think there actually is in a perverse way, a shared destiny. Harming patients and then turning the harm on yourself because you can't bear the thought of living with the mistake that you've made. And my heart goes out. I wouldn't wish a medical mistake on any colleague. And yes, we are. And there's this whole literature of referring to health professionals as the second victim of medical malpractice. And once patients and their families caught wind of it, they said, "How dare you? I lost my father. How dare you talk about being the second victim?" And so we can't talk about that. But I can tell you that it is an experience that we should all strive to try to prevent if we can by learning the lessons that are out there.
And it reminds me of those three little words that you write about in The Night Shift, which also ruined a Jack Johnson song for me that I liked by the same name. Do you remember?
Yeah. Yeah.
Can you speak to that a little bit? I don't know if all of our listeners and viewers will have.
Sure. That was kind of the framing device of my TED Talk, and I wrote about it in The Night Shift, and I talked about it in my TED Talk, that the three worst words an emergency physician will ever hear are "Do you remember?" And it's usually the beginning of a story. Do you remember that patient you saw last week? Now, it's not always, if you practice long enough, you might discover that it turned out that they had this diagnosis. And so, we were able to address the problem. But in our worst fear, "Do you remember?" is the beginning of a story that the patient died after you sent them home. And I interviewed a number of people. I had them on White Coat Black Art, including one physician who had seen a young adult with autism spectrum disorder, ASD, autism, who would be brought to the emergency department by his caregivers to receive an enema because he got constipated and he got bunged up and needed to be disinfected. And this emergency physician, was urged, he's yelling and screaming, "Can you get him out of here?" And he acceded. He agreed to the enema. He didn't take another look and sent the patient home and came back a few days later for his next shift and was told, following "Do you remember?" "Yeah, I remember that patient." Found out that he died, and at the autopsy he had a ruptured appendicitis, and he died of septicemia. I think that, I haven't thought about the phrase "Do you remember?" By the way, I can tell you there's another three words that emergency physicians don't like to hear, and that is "You look tired." We were talking about that a little while ago because you've been beat out, because an astute emergency physician knows how to get enough sleep. Can you imagine how would you feel if somebody admonished you to get more sleep or you'll be fired? I think I would go home and be preoccupied with, boy, I better get to sleep tonight. Yeah. And I'd be pounding the pillow and I'd get 4 hours of sleep and I'd be sleep deprived.
And not to mention just the length of your shift, but switching between day shift, night shift regularly, the effect it has on your circadian rhythms and the quality of your sleep, not just the quantity, but the quality of your sleep, the amount of time you spend in REM versus your deeper sleep.
And you know what, I was one of the first I've been practicing over 40 years, and I was one of the first to bring chronobiology into the shift work that we did at my hospital. I was one of the first to say we should be going from days to evenings to nights, and then have a suitable period of time off. And we've done that. I think that across other disciplines in medicine, they've gotten into shift work. Shift work is actually better than being up for 36 hours. And so doing, for instance, having an obstetrician doing night duty, arriving at 7 p.m. or 8 p.m. and being there for the rest of the night, or having 3 shifts a day. It's hard to do that because there's fewer obstetricians than there are a lot of other kinds of professionals. But that would be, and that's actually an advance. You've talked about, I know the sense I've got from you is that you're thinking about shift work as you've got to do it right. And if you don't do it right, you're going to have people who are sleep deprived, and that is true. But I can tell you that shift work, for an anesthesiologist, is far better than having them up all night. Working all day, being up all night, and then having to go to work the next day, and function during the daytime. Having shift work, I think, is actually an advance, and that may be surprising to people who are steeped in aviation and shift duty schedules for pilots and other cockpit crew.
I wonder if going back to the reluctance to share errors, some of it might be down to the language around error and the fact that we're talking about mistakes, and therefore there's a shame involved with a mistake. Whereas in military aviation, at least in the Canadian Forces, you really hear those terms being used. The term flight safety is used as a catch-all for anything. So it could be a mechanical error, it could be a bird strike, it could be a misinterpreted clearance or a miscommunication, or it could be a mistake. All of those would be a flight safety. So the pilot, the crew, whoever's involved gets down from a trip and they'll say, I think there was a flight safety. I think we should write up a flight safety. And then the flight safety is written up. And then the directorate of flight safety takes a look at it, and if there are preventative measures, they publish preventative measures for everyone. It fosters a just culture where you know that there's no punitive measures involved, because what you're trying to do is bring people's attention to something that's preventable. I don't think I've heard people use the term there was a mistake or there was an error. It's usually there was a flight safety. And I wonder if something similar to that in healthcare, it might start to move people away from the mindset that I can't talk about it because it's a mistake. Maybe it's a trauma resus safety, or it's a medical safety or something. And it's a nomenclature thing, but perhaps
it's an interesting thought. My sense is that people in healthcare would see through that, and they would be thinking, "Oh, yeah, they want to know who to blame." Right. This is just code for who to blame. And
how important is anonymity? How important is anonymity then? And if we're talking about let's share as much information as possible with as many people as possible, to do it in an anonymous way where hey, there's going to be no punitive measures here. I just think people ought to learn from this, and not even necessarily learn from a mistake, but something could have happened but didn't happen. We had a near miss, and it's probably not going to be captured anywhere or reported on, but I think other people outside of our hospital or outside of our healthcare region ought to know about it, because it'll probably happen somewhere else too. It's a matter of time.
If you believe, as many people do in healthcare, that good doctors never make mistakes, then all of that effort is extra work that you made us do. Like, see what you made us do. We had to have a morbidity and mortality rounds because of your mistake. See what you made us do. I sound utterly cynical, but I haven't seen this change. I haven't seen this change in decades. And And there will be. I mean, I'm sure there'll be healthcare providers who will look at this conversation who will say, "Oh, Brian, you're decades out of date now. We don't do that anymore." Well, I can tell you that, and it takes a special person. Maybe I'm thinking about antiquated or outdated leaders who subscribe to that. That view that the most expeditious way to deal with a mistake is to find someone to blame. So you can say we've solved the problem because we've punished the guilty.
Right. Are you seeing any developments or advances in terms of maybe flattening the hierarchy or the power gradient a little bit, more developmental teaching, more Socratic method, maybe more empathy towards residents instead of putting them through the punishment of a rite of passage?
I think there is some of that happening, and certainly there are venues where residents can discuss cases in more of a just environment where they're able to say what they've seen and talk about it, and in a way that is that's healthy. They're able to share their experiences. They're able to talk about how they feel. I think there is more of that than there used to be. Yeah.
What kind of tools are out there for that? I mean, we've got. You mentioned in teamwork the use of EFNER, I'm not sure if that's pronounced, and retained tabletop and digital games as proxy simulation to reduce errors by encouraging participants to speak up where they see a way to improve care.
There's tools that have been created for and by the Canadian Patient Safety Institute, based in Edmonton. There are there's Greg's Wings. Greg was a man who died of metastatic testicular cancer. He actually had a blood clot, in the days following surgery, in the immediate aftermath of surgery, and his family created Greg's Wings as a teaching device so they created a documentary. They paid for a documentary that described his journey through the healthcare system. In an effort to provide lessons, and those lessons have been taught to medical students, residents, allied health professionals, and so there are these teaching tools exist. Elaine Bromley, who I talk about in The Power of Teamwork, her husband Martin Bromley, an airline pilot, a commercial airline pilot, created a trust called Human Factors Research, based in the UK, and his Human Factors produced a documentary called Just a Routine Operation, and described what happened. And in my book, The Power of Teamwork, I talked about that particular case. This is a woman, his late wife, Elaine Bromley, a young mother at the time, who went into a private hospital in the UK for a routine sinus surgery, and within 25 minutes, 30 minutes or so, 45 minutes, had suffered irreversible brain damage because she had a complication, a rare complication, which I guess is the equivalent of a stall in aviation. It happens in the operating room. The anesthetist tried to insert an airway to oxygenate her. He was unable to insert an airway, and he was unable to oxygenate her, and she had been given medications to stop her breathing, to sedate her, to make it easier to insert the airway device. And she had a recognized complication called the can't intubate, can't oxygenate, KICO, also sometimes called the can't intubate, can't ventilate scenario, for which there is a fix, and that is a surgical airway, tracheostomy. So this video that's basically an hour, like a minute, not hour, but minute by minute account of what happened to Elaine has been used the world over to teach anesthesiologists and emergency physicians like me, because sometimes we have this kind of a clinical scenario, and I talked about the reason I talked about this case and used it as a framing device for my book, The Power of Teamwork, is that I believe that teamwork is one of the answers to reducing errors. We haven't talked about this yet, but I want to talk about it because I think teamwork is important. In that, teamwork means that you have a leader who has situational awareness, who is managing a team and not doing the job of the team members. So there was nobody in the operating room who noticed, who could say, what's our situation right now? What's the sit rep? And you need that in aviation. What have we got? Bird strike, 2 engines knocked out. No, avionics failed. Like, we have a glider here, and nothing else. That was Sully Sullenberger's. He had situational awareness. But in that operating room, you had 2 anesthesiologists. The second one joined the first one, and then the ear, nose, and throat surgeon, who was supposed to be doing the operation, each sequentially trying to secure the airway, each failing. And in fact, there were nurses who came in. One nurse who said, "We've secured a bed in the ICU." This was a patient who was supposed to go home after an hour and a half, routine surgery, elective surgery, and go home. Why have you, what you needed? Why would you tell me that there's an ICU bed available? And maybe the nurse might have replied in a culture with a flattened hierarchy, which we talked about, that, well, I've been looking at the oxygen saturation, needs to be, north of 90, and it's been in the 40s for the last 5 minutes, and set your stopwatch 10 minutes, and they might have irreversible brain damage at that point. And then another nurse said, in a still small voice, I brought the surgical airway tray in, to do the tracheostomy. What did you see that made you say that? And I in the book I talk about ways of using that information.
Was that the say it culture?
See it, say it culture. Do you have that in crew resource management?
I believe we do. Yeah,
I believe you do. Yeah, we do. And we don't have that in. Now we've started to have it.
Okay.
And we are doing. And I don't want to make it like we are practicing more teamwork. We are doing more simulations where people are able to act out their different roles, including acting out the role of leader, so that they can learn that their job isn't to fix everybody else's problems, but to ask the questions that gathers the wisdom of the room.
The use of simulation. Kind of going back to the Code Orange, we talked about the mass casualty event and how the simulation occurred prior to that, and it prepared everybody to do much better, to perform much better as a team. That's obviously second nature for aviation, and any operational crew will go through quarterly, biannual, or annual recurrency, emergency flight training devices, emergency simulators, where exactly as you described, the worst possible scenarios are thrown at the crew for 4 straight hours, and then you switch from the role of, for example, pilot flying to pilot monitoring, or vice versa. If you're conducting a recurrency with another aircraft commander or an aircraft captain, then one of you will be a first officer for 4 hours, and the other one, and then you'll switch, so you get an opportunity to be the leader as well. You have a chapter there, Dr. Niall Downey, cardiothoracic surgeon and commercial pilot.
Yep, probably the only one on the planet, I would think.
Must be rare.
Yeah.
But you should probably apply to a European Space Agency for astronaut with it's about the only credential left off his resume. So in that chapter, you're dealing with crew resource management, how it's applied in aviation, how it could be applied.
Yeah.
And I believe you mentioned a little bit on threat and error management as well, because you talk about the various evolutions of crew resource management in aviation. Can you expand on that a little bit?
Sure. I think the idea, and I built it very slowly and carefully. So the say it, see it comes from something called visual thinking strategies, and this is just a technique that was designed to increase the enjoyment of museum goers in the experience of viewing exhibits, in an art gallery or a museum, and it was born out of the idea that they said they liked, museum goers said they liked the experience, but they were getting nothing out of it. And frankly, and so this was the idea behind it is to plunk people in front of a work of art, people who know nothing about art, and you don't have to have a degree in art. You don't have to have a degree in art appreciation, and ask them 3 questions. What do you see? Sculpture, painting in front of you. What do you see that makes you say that? For instance, I see a woman in bed. I see a woman who looks sick. What do you see that makes you say that? Well, her complexion is different from the complexion of all the others who are around her. And then you ask a third question. What more can we find? And that invites other people in the group to say what they see. You know, someone else says, I see medicines on the night table, or I see a crucifix in the background, or I see a woman standing over the woman in bed who is holding a palm leaf. And the whole and this has been used, adapted for medical students. So in the book, in The Power of Teamwork, I talk about Alexa Miller, who adapted this for medicine. So she, in a pilot program 20 years ago, plunked first-year medical students from Harvard Medical School, delivered them from the medical school across the street to the Museum of Fine Art, plunked them in front of a work of art, and asked those questions. What do you see? What do you see that makes you say that? What more can we find? And the whole idea is to develop something called team cognition, which is a relatively new concept, but the idea that in aviation that everybody in the cockpit is getting a sense of what the emergency is, and that each person with their unique perspective and unique experience is able to contribute things that can help assist in developing overall situational awareness. The other thing that it's doing is creating, this is really important, is creating a culture where you feel safe to say what you see. Without that, planes are going to go down and patients are going to die. And can you develop that? Yeah, you can. And through the simulations that we're doing, Protected Code Blues, learning how to get past making mistakes and learning how to cope with unforeseen circumstances or barely foreseen circumstances. Yeah, I think that is, it offers a great hope to improve safety in healthcare.
And the exercise wouldn't work if it was one-on-one. You need the group there to provide the additional information on what else do you see. And
you need people in their roles. So if you have, for instance, a multidisciplinary resuscitation, you want surgeons to play surgeons. You want nurses to play nurses. Now, there is benefit to rotating so that they can empathize with, so that a surgeon, for instance, can empathize with an anesthetist, or an anesthetist can empathize with a surgeon, and that's important because sometimes you need that to appreciate that you're not the only one in the operating room.
How often are simulations conducted with a multidisciplinary team outside of the training context, outside of med school or the university?
I think it's neither. In both cases, it's seldom. And they tend to be special events. They tend to be special events, and like the Code Orange that I talked about with OC Transpo, where the Ottawa Hospital did a Code Orange simulation. And then you want people in their roles because you want them to be able to function. You want to be able to predict how they'll function, and in a real scenario, and you want to be able to uncover as many of the potential errors or bad outcomes as possible. I think that the limitation with multidisciplinary simulation training is that it's hard to coordinate schedules to get everybody available on the same day.
Yeah, that makes sense. I mean, on the one hand, a culture won't remain strong if it isn't nurtured. It'll be eroded by other norms over time. So there's a repeatability requirement in order to maintain a certain standard. But on the other hand, you have the complexity of scheduling, which we already talked about how fatiguing it is to be a resident, and part and parcel of that is I'm sure there's just not enough people in any of the medical professions. I imagine that scheduling is the way it is in part. Not just because it's a rite of passage, but because it's the pragmatic solution to try and squeeze as much as you can out of the people that you have available.
Yeah. And we have, I think we're constantly fighting the enemy of time pressure in healthcare, and that may be one of the major differences between. I'm not sure, because I know that airline schedules are very. This is partly or largely about profitability, because the margin between profitability and loss is, a lot of airlines are in the red a lot of the time. And so on-time departures are important, and yet you'd want to have on-time departures with a safety culture. We are in healthcare constantly facing time pressure, particularly in the emergency department. My head is on a swivel. I'm like a pinball. I'm just bouncing from one thing to another, to another, to another, to another. And the ideal scenario, the ideal way of doing simulations would not be to have a scheduled simulation, but to have an in situ simulation where we hear, code blue, room 52, and everybody comes running to code blue, and they discover that it's a Resusciani doll, and that's probably the best way to do it, and you have it on the ward where they work, so that they can't say, I've gone to the special simulation training center where none of the equipment is the equipment I work with. It's their equipment, their supplies, and they uncover very quickly, that they don't have adequate supplies of epinephrine and other resuscitation drugs, etc.
How much agency would you have as a physician to create that simulation without needing to go necessarily through, say, hospital leadership?
On your own ward, well. If somebody accused you of compromising patient care because everybody in the emergency department was preoccupied with attending to this fake emergency, the simulated emergency, when patients were meanwhile in the waiting room who were waiting to come in, I think we're very good at raising objections, but that certainly is that's what Glenn Posner does. He's an OBGYN in Ottawa who runs these in situ. He's the one who carries dummies around. That's and people are kind of pissed off when they come into the room and realize that they're resuscitating a simulated patient. But the intent is to. So I guess you need a maverick. You need a maverick who says this crazy idea might just work.
Maybe your fifth book will be The Power of Leadership, and that'll be the maverick in the discussion.
Yeah.
Were there any particularly strong teams that you've worked with throughout your career that came to mind when you were writing The Power of Teamwork?
Personally, yeah. I would say some of the strongest teams that I've worked on are the ones I'm working with right now. In the emergency department at Sinai Health System. I'm not just touting at Sinai because I work there. There have been some very strong leaders. Like there was a time when we worked. We provided solo coverage. I remember on a Saturday, Saturdays and Sundays, we were on for 12 hours, and we were the only physician on duty. We had to see every patient over a 12-hour period, and then we'd hand over to the night doc, or the night doc would hand over to the day doc. Now we have triple and often quadruple coverage. So first physician arrives at 6, second arrives at 9, third one arrives at 11, fourth arrives at 1, fifth physician arrives at 4 p.m., and then the sixth physician arrives at 6 p.m., and the seventh physician at 9 p.m., the night doc arrives. And they're working for typically 6 to 8 hours. So you do have a pool of colleagues who are available. So the first thing I've noticed is that once you start having triple and quadruple coverage, you can have crosstalk. You can have one physician saying to another, I'm having a little trouble with this patient. Look at the ultrasound I just did. What do you think of that? You have I'm thinking of one of my colleagues who showed me a better way of reducing a fracture, just because he happened to be around. In fact, he was doing anesthesia when I was doing the reduction, and he just said, "There's a better way to do it," and he taught me right there. So, I don't remember that team spiritedness, and it may be that maybe younger physicians. He's younger than I am, but I have some idols now. I have some heroes that I work with who are younger than I am, and maybe that's
very promising. Is there something unique about Sinai that is that perhaps other hospitals, not just within Ontario but elsewhere in Canada or further afield, could learn from?
Oh yeah, I think that I think Sinai can teach it. I think University Health Network is good. A lot of the hospitals in Toronto are learning, and about the teamwork model. My colleague Sev Perlman directs the simulation center at Sinai, and he's taught simulation training around the world, he's another person that I respect greatly. I would say as well. I mentioned the Ottawa Hospital. It tends to be teaching hospitals because they're teaching the next generation of physicians, and then, there's good simulation training in the United States as well.
Is that primarily how good practice is fostered? Is that the teaching hospitals, or is there another way to get across interesting, novel ways of new ways of doing things?
Sure.
You mentioned an interesting study published in the Journal of the American Medical Association in 1999 that found the average length of time physicians let a patient speak before interrupting was 18 seconds.
Yeah.
And once interrupted, the patients never got back to fully describing the situation.
Right.
And so you noted how silence can be used as a technique for gathering more information about a patient's background. And I wondered when I read that, how many other physicians know that? And are there avenues outside of a teaching hospital where you're communicating with one another on a relatively regular basis with just interesting, perhaps non-medical tips like that, the use of effective silence to improve your diagnoses?
I would say that WhatsApp is probably the vehicle of choice, the medium of choice for sharing that kind of information.
Is that because it's encrypted and people feel a little safer using it?
Yeah. It's time consuming. Okay. Because when you have a group of 35 or 40 physicians who belong to the WhatsApp group, there's a lot of postings to go through, and if you haven't checked in, you could there could be 30 in a day, could be 30 or 40 or 50, even 100 in a day, depending on how spicy the topic is or how pertinent the topic is. But that's one way that we do it.
All right, so we're getting to the end of our conversation here. Mm-hmm. I do have to thank you very, very much for your time this afternoon.
My pleasure.
There is a ton of overlap between aviation and healthcare, and I could talk about it with you for hours. Mm-hmm. I think I'd like to finish up on a quote from your book, your most recent book on teamwork, and then I'll let you close it out with your thoughts on this quote. Mm-hmm. Every single day without fail, if I tried to do my day on my own, every single day there would be an element that would not function as well because without the team, I wouldn't have the input of somebody else.
So that was uttered by Dr. Jonathan Fitzsimon, who is a family doctor in Arnprior, which is part of Renfrew County. It's in the lovely and austere and remotely populated part of northeastern Ontario that encompasses the Ottawa Valley, Algonquin Park. The county of Renfrew has, in addition to stark beauty, it has some logistical problems. It has a large number of older patients who don't have a family doctor and who, if they can't drive a car, can't get to a medical facility. There are almost no walk-in clinics. There's no public transportation. And so they have two options. They can call 911 and be brought to an emergency department, or they can sit at home and get sicker and sicker. Or, maybe if they've got a loved one, an adult child who can transport them to a doctor's office, then that would be helpful. So in that system, they discovered that they had a huge problem, and that is, how do you care for people who don't have a family doctor and don't have access to health care? And they invented a teamwork model that is that is now inspiring similar efforts across Canada and around the world, where you have Jonathan Fitzsimon, who's functioning as a family doctor. If he had to go out and do house calls on every patient, he'd be spending his entire day driving from place to place. Well, that's not very efficient. So he stays in his office. There is a dispatcher. There's a toll-free number that patients can call, and it's for unattached patients who don't have a family doctor, and they get plugged into the system. And they'll talk to either a family physician like Dr. Fitzsimon, or they'll speak to a nurse practitioner. And if it would be beneficial for them to come to the office, if someone can transport them there, fine. If they can't, then they'll send a paramedic to the patient's house. and they function as the eyes and ears of the primary care provider. They can take vital signs. So this is a different kind of paramedic. It's not the paramedic who is a first responder to emergencies. This is a paramedic who arrives in a specially equipped vehicle. They have special training. They can do sutures. They can put in IVs, which every paramedic can do. They can take vital signs. They can do point-of-care ultrasound, electrocardiograms, blood work. They can deliver medications. And, this system was in place prior to the pandemic, and with the pandemic, they had the added pressure. In the early days of the pandemic, they didn't want patients with COVID to be brought to the emergency department if it wasn't necessary. So they developed something called the Virtual Triage Assessment Center, VTAC. And so this was a toll-free number that patients could call and could get advice on managing COVID, could also, by the way, get advice on managing everything else. And they were accepted and recruited into a team where the team would consist of a family physician, nurse practitioner, nurses, community paramedics as the eyes and ears doing the house calls, registered dietitians, psychologists, physiotherapists, occupational therapists, speech and language pathologists as necessary, pharmacists, all functioning in a teamwork model. And what they found is that they were able to take care of patients who previously had no family doctor, who would have had no option but to go to the emergency department. They were able to dramatically reduce the number of unnecessary visits to the emergency department, and they did it without transmitting COVID-19. And the program was so successful that it recently received full funding to carry on indefinitely. We should all be doing something like that. Now, one of the things that people who've been watching the healthcare system as I have for decades, we get tired of pilot projects that go nowhere. This thing can be scaled up, and we know, for instance, that community paramedicine in Alberta, which also has austere and remote areas of the province that are not well doctored. Well, in a teamwork model, you can look after those patients where they live. And I think this is the kind of thing I'd like to see right across Canada, and certainly in the United States and around the world. And it's the brainchild of Chief Michael Nolan. Michael Nolan is the director of paramedicine for the county of Renfrew, and he's a visionary management expert who has learned how to get the different silos. The hospital culture, the family medicine culture, the specialist culture, paramedicine. Other first responders to play nicely with one another, and it takes a special kind of leader to be able to make that kind of thing happen. He's done it very well.
It's nice to finish on a positive note.
Yes, it is.
It's a positive story.
Teamwork works. Teamwork saves lives in aviation. It saves lives in healthcare, and the more we espouse to the principles of teamwork, not only will we do better, but we'll feel better. We'll actually have less burnout. Fewer accidents, better safety record, better job satisfaction, and a better sense of bliss, ecstasy from all of us doing a job well done. Like, when was the last time you said, we did it? We did it. We all did it. And I think that's the juice of healthcare, just as it's the juice of aviation as well.
I couldn't agree more. Thank you so much for your time, Dr. Goldman. I encourage our listeners and viewers to go out and purchase The Power of Teamwork, and to take a look at White Coat, Black Hat, because it's an excellent podcast.
Thank you.
Even for folks like me who aren't healthcare professionals, a ton of overlap with aviation and thoroughly engaging. So thank you so much for your time this afternoon. Wish you all the best, and I hope I'll see you again in the near future.
You bet. Me too.
Cheers.